And welcome back. We hope you enjoyed that break session with Dr. Brandon on grounding techniques. Stay tuned throughout the program over the next 2 days, and we'll have more sessions on how different techniques can be used for chronic illnesses throughout the week. And so we are going to start our next session, but we did have one enduring question from this morning's session, John, and it was on your talk, and it was about PPIs and some confusion about, especially around testing with PPIs and when they work or when they don't work. Can you just maybe quickly circle back on that?
So proton pump inhibitors are very effective medicines at reducing acid in the stomach, and they're a treatment for reflux disease. But it's very important to remember that it doesn't work for everybody, because maybe it's not reflux related to acid. It can be non-acid reflux, volume reflux. So it's really important to realize that they're great medicines, but they're not perfect. And many times we will be doing physiologic testing to assess reflux. And the way we do the testing is really important, because you really want to focus on the question. So if the question is, do you actually have reflux? You wind up taking people off the proton pump inhibitor and studying them off the medicine, because then you're looking to see if they have abnormal acid exposure in the esophagus. So if the first question is, do you have reflux? That's how we answer it. We take you off the medicine, and then we look for the abnormal acid exposure. The other question that we tend to ask is, why isn't the PPI working? Why is that proton pump inhibitor not working? And in that case, we will study you on the medicine to see why the medicine is not working. Sometimes it's not effectively suppressing the acid, and you are getting more acid in the esophagus. But sometimes you're actually having non-acid reflux. The medicine may be controlling acid, but because you have a hernia or a sphincter that's open, you're having non-acid reflux. So it's really important to remember that you're trying to use the medicines and do the studies on medicines or off medicine to ask two specific questions.
Okay, well, that makes so much more sense. And we thank you for your question from the audience that came in this morning. Apologize we didn't have time in the earlier break to be able to discuss that. But thank you, John, for clarifying that for us. And we will go ahead and move into our next session. John, you want to do that?
Yeah, so we're moving on, and the next session, session 2, which is our short bowel syndrome and intestinal failure, we're going to have a dual approach here with a gastroenterologist and a surgeon. Dr. Adam Stein is a gastroenterologist who actually focuses on small bowel disorders, small bowel absorption and nutrition. He's an expert in hyperal and nutrition through the vein. He's going to be complemented by our surgical colleague, Dr. Mercer, David Mercer, who's at the University of Nebraska, who really is a transplant surgeon, really went there to start an intestinal failure unit, intestinal transplant, and liver transplant unit, but really has become primarily focused in intestinal rehab. So once again, when the small bowel is not working. So we've got a great opportunity to hear from a gastroenterologist and a surgeon on these disorders. And the other section that's going to be really nice with this is that this is going to be complemented by two patient stories. So we have a patient perspective on short bowel syndrome. Swapna Kakani is going to talk about her life experience with this and how it's impacted her. And then we're going to look at someone who's had to deal with intestinal failure, and that's going to be John Mahalchak. And he's going to talk to us about living with intestinal failure. So a really nice session where we go from the physician perspective to the patient perspective.
Thank you, John. And just before we start that, I will remind you that some images that are presented in these presentations may be graphic. We are hearing from a surgeon, and there will be images during Dr. Mercer's presentation that are during a surgical operation. And so those are very graphic images of the human body under surgery. So that's just a warning for those in the audience who might be sensitive to that sort of thing, that Dr. Mercer's talk will have some graphic images. But we will go ahead and start this panel discussion and panel presentation with these four speakers.
Thank you very much for allowing me to talk to you today about short bowel syndrome and intestinal failure. Thank you to IFFGD for inviting me. This is going to be just a broad overview of intestinal failure, which includes short bowel syndrome. The biggest thing to know about intestinal failure and short bowel syndrome is that The intestine is a very unique organ. Different parts are responsible for doing different things. And depending on which part of the intestine is potentially impacted will depend on what sort of problems you might have associated with the intestine or short bowel syndrome. And just to keep in mind, a general overview of the digestive system is as things travel through the GI system, they go to the esophagus, stomach, duodenum, which is part of the small intestine, jejunum again, which is part of the small intestine, and ileum, part of the small intestine as well. And then they finally go into the colon. So this is an overview or a map of the intestinal system. And it shows what areas of the small intestine in particular are responsible for absorbing and maintaining your health. So as I eat something, it travels through the esophagus, through the stomach, into the small intestine. The duodenum is the first part. That's primarily responsible for absorbing heavy metals, things such as iron, copper, magnesium. Then it travels down into the jejunum, where sugars and proteins are starting to be absorbed, and then finally reaches the ileum, where things like fat and fat-soluble vitamins are absorbed. The very last part of the small intestine, called the terminal ileum, has a very unique role in absorption of a certain vitamin called vitamin B12, bile, and even more fat. The stomach and the colon don't really absorb a whole lot. The colon mainly absorbs certain fats, but mostly water, and water is absorbed throughout. So intestinal failure is a broad umbrella term, meaning the intestine is not absorbing what it needs to in order for you to maintain your health. Short bowel syndrome is a term under intestinal failure that means part of the intestine has been removed. And part of that intestine that has been removed causes you to have nutrition issues. And just like this real estate map shows, what part of the intestine is, it really depends what part of the intestine is removed in terms of what sort of health issues you might have. So intestinal failure, by definition, is when the body is unable to absorb enough fluid or nutrients to stay healthy. Many different causes of intestinal failure, short bowel syndrome being one of them. But really, when you talk about intestinal failure, there's two groups of things that could potentially happen. One is having a medical condition that leads to problems with absorption of either fluid and or nutrients. And then the other is a surgical condition where surgery leads you to have these issues. Under the medical condition umbrella, there are many things that can cause the intestine to fail. I've listed several of them here. There's more in your packet, but in general, there's either anatomical issues, flow issues, or issues with the tissue itself. So anatomically, you can have blockages or obstruction. Things like tumors can block flow through the intestine, scarred tissue. You can have congenital disorders like Hirschsprung's disease, so on and so forth. Cancer, beyond tumors, can also cause issues with intestinal absorption. If you've had radiation, sometimes radiation can damage the intestine. Other cancers can cause proteins to build up in the intestine, such as amyloid, which block nutrients and fluids from being absorbed into the intestine. Beyond that, you can have issues with flow, or what we call motility, through the GI system. People whose stomachs don't work, that's called gastroparesis, they can eat, but the food doesn't travel past their stomach, so they get problems with pain and things like that. You can't maintain your nutrition like that, even though the rest of your intestine works. You can't get food through the stomach to get to the rest of the intestine where things get absorbed. There's other issues with pseudo-obstruction. People with systemic sclerosis, which was formerly called scleroderma, and things like that can also have flow or motility issues, which cause you not to be able to take in enough fluid or nutrients. When you have issues with the actual tissue itself, like inflammation caused by Crohn's disease or problems with blood flow to the tissue itself, you can get food and fluid to the areas of the intestine that they need to go, but the tissue itself is so damaged that it can't grab onto the nutrients and then absorb it into the body. So all these things are medical conditions leading to problems getting enough fluid or nutrients into the body. Now, surgery is a unique thing in terms of it causing problems with fluid and nutrient absorption. Typically, the causes of intestinal failure from surgery are due to removing extensive portions of the small intestine and or stomach. So when a surgeon goes in and removes parts of the intestine for whatever reason, could be Crohn's disease, could be cancer, could be ischemia or problems with blood flow, you're left with a shorter area of intestine that's responsible for absorbing, and that absorptive capacity or that area of the intestine that is left behind just really isn't big enough in order to absorb as much fluid or nutrition as it needs to. Put it another way, your small intestine, which again is responsible for most of the absorption, is about 15 or 20 feet long. That's a lot of surface area to absorb a bunch of stuff. And if you sliced open the small intestine, laid it out flat, all these peaks and valleys, which are called villi in the small intestine, you laid those flat as well, it would be somewhere in between the size of a tennis court to a football field. Now, if you start removing big chunks of that, you can imagine that all of that surface that's normally used to absorb fluid and nutrients is taken away. And when food and liquids flow through the intestine, you might not be able to absorb as much as you need to in order to survive. And that's called short bowel syndrome. The other cause surgically of intestinal failure is when somebody has an ostomy or part of the small intestine or a colon is brought out to the skin, and instead of emptying when you sit down and go to the bathroom to have a bowel movement, it empties into a bag on the belly. That's fine in and of itself, but sometimes people can empty too much. That bag or that ostomy leads to rapid flow of contents through the intestinal system, and it flows through so rapidly you just can't absorb enough. So that's called high ostomy output. That's another reason people could have intestinal failure. So what do you do about it? When you have intestinal failure, things such as short bowel syndrome or the other things that we just talked about, how do you treat that? How do you fix that? The main thing you need, in my opinion, is a strong medical team around you. This diagram came from an article published 7 or 8 years ago that goes into detail about what sort of team you need if you have intestinal failure. You need somebody who's going to be your quarterback, who's going to oversee your medical treatment. In this example, this is a gastroenterologist, but it could be a surgeon, it could be a primary care provider, somebody else, but somebody who's going to oversee everything and make sure that you get the treatment that you need. Everybody with intestinal failure is a little bit different. There's no two people alike who have intestinal failure, mainly because there's so many different things that come into play when you have intestinal failure. So when you have intestinal failure, you need a team around you, and you need a multidisciplinary team, not only your quarterback, but also people like dietitians, pharmacists, radiologists. Sometimes you need a nurse or an infectious disease provider, other people who can help oversee your care and contribute when bumps in the road happen. Because when people have intestinal failure, bumps in the road do happen, and that's okay. But you need an individualized treatment plan, and you need a medical team surrounding you. So this diagram is a useful tool to look at and show your team just to make sure you have everybody you need. So with your team surrounding you, and that's easier said than done, but with putting together a team, there are a number of different steps that we go through in order to make sure people with intestinal failure get the treatment that they need in order to maintain their nutrition and hydration, their health. Step one, first thing is hydration. You need to stay hydrated. Hydration is the thing that is going to injure you or potentially kill you the fastest. If you're dehydrated, you're going to have problems with your organs, mainly kidneys, but other organs can be involved. And if you are dehydrated for long enough, your kidneys can shut down, and that can be significant to your health and could even cause death. So hydration is the most important treatment to think about. So things like drinking enough fluids, and the fluids that we tell people to drink are non-caffeinated, without artificial sweeteners or things like that. Caffeine is a diuretic. Artificial sweeteners move through the system very quickly. And we ask people to eat first and then drink. Your dietitian, your gastroenterologist, primary care, they can design a drink menu for you, which includes both liquids as well as different amounts of fluid that you need to drink every day. Step 2 is eating. Not everybody can eat by mouth. Some people have tubes, some people get fluids and nutrition through an IV, things like that. But you need to maintain your nutrition. After your hydration is taken care of, nutrition is next. You need, if you can eat small, frequent meals, snacks, those are great because you don't want to overwhelm the system all at once. You want to keep the system going at a regular rate. If you have a feeding tube, that's certainly fine. You need to design a feeding tube plan with your dietitian or physician and then finally, if you need IV nutrition, that's called TPN, we manage that as well. The third thing in terms of treatment that you need to have in mind is medication. There are a ton of different medications that we can use to help with absorption, fluid balance, things like that. People use acid blockers, not for heartburn necessarily, but to reduce the amount of fluid that your stomach and small intestine produces. We use medications to slow down the intestine, things like loperamide, diphenoxylate, opium tincture, and codeine. That's to slow things down so that the intestine has the ability to absorb better. The slower things move, the more time there is to absorb. And then finally, we have hormones that we can use, things like octreotide or teduglutide. Those not only help with absorption, but they can actually increase the number of cells that are available to absorb things. They don't necessarily elongate the intestine, but they cause all those cells to grow and divide, which allow us to absorb and pick up nutrients. So this is just a general overview of intestinal failure. Please look at your packet for more information and ask questions as things come up in the multidisciplinary session. Thank you very much.
Hi, everyone. I'm Dave Mercer. I'm a professor of surgery at the University of Nebraska Medical Center, and I direct our intestinal rehabilitation program. I'm one of the transplant surgeons, but I must say I spend most of my life trying to avoid doing transplant surgery wherever is possible by helping short bowel patients to become TPN independent wherever they can. So they've asked me to give a little talk today on surgery and short bowel syndrome, and it should build off of the talk that you had from Adam. And so I won't go into too much detail about short bowel syndrome and what it is. And really, we'll talk more philosophically about surgery because in a short 10-minute talk, I can really just introduce the basics and some of the simple concepts. I just have a few disclosures. I'm fairly involved in all of the clinical trials in our field working on growth factors. None of the growth factors really have an impact on my talk today, but sometimes when I'm talking about things that get me excited and about where the future of the field is, I could allude to some of them. And so just to let you all know that that's the work that I'm doing. Okay, so I told you this was going to be philosophy, and that's what a lot of it is going to be. So here's my first sort of philosophical point about surgery and how surgery relates to short bowel syndrome. So there's many different surgeons who are involved in the creation of patients with short bowel syndrome. But I would say there's very few people who should actually be involved in treating it. So what do I mean? Well, for anyone who's a patient out there watching this, you all would have had a surgeon, whether it was when you were a child or it's been a series of surgeries as you're an adult, or perhaps some more singular catastrophic event that led to the loss of a lot of your absorptive surface. So that's going to be whatever surgeon happened to be around or was treating you at the time that the event occurred. For those of you that are medical professionals, these are well dispersed across the whole population. Now, the thing is that people that are forced to deal with these emergent situations or who are doing the different operations where perhaps bowel gets removed are not necessarily the same set of people who should be dealing with the consequences once the patients are already short. The surgery becomes pretty specialized. And I can tell you one thing about surgeons being one is we kind of have sometimes the arrogance of the idea that we can really look after everything. And, you know, we all like to think that we're good surgeons and we do good technical work, and I'm sure most of us do. But the issues that come in treating patients with short bowel are very, very specific, and the details really do matter. And I think that the surgeons need to be intimately involved with the team that are looking after you. In our program, I'm there with every patient along with my GI colleague. It's going to be different in different places around the country, but what you really don't want is sort of the surgeon du jour, you know, somebody who's just happens to be the person who's around that day. Because while they may be able to perform the simple mechanics of the operation, they don't necessarily have the investment in the decision process that's involved in things. And I'll touch on that a little bit later on. This is a great big figure that I put together for a chapter in a textbook. And most of it doesn't matter to any of you. I just wanted to make the simple point that if something happens and you lose absorptive surface, so that means a bunch of intestine gets lost. Well, what do? Initially, you stabilize that patient. You start the parenteral nutrition, start them on their TPN if that's what they need. And then you really want to look and say, okay, are they truly short bowel? Did we lose quite a bit? Maybe we're at 50% of where we should be or something like that. And what I'm going to say is very simply, almost every one of those patients should be considered for transfer to a specialized intestinal rehab center. Now, that doesn't mean everyone in the country has to come to Nebraska. That would be great. You're all welcome. But certainly there's centers of excellence at different spots around the country. They are relatively few and far between in the adult population, a little more well-developed in the pediatric population. But I think this is really important. It doesn't mean that everything has to be done in a rehab center. It doesn't mean you have to give up a relationship with a surgeon who you really, really trust and you've been with for a long, long time. But you probably need a little bit of input. That person could end up doing your surgeries, but it helps to get some input from someone who's seeing a lot of volume, someone who's looking at all of these issues, especially as you get into the more esoteric and rare operations. Okay, so let's talk a little bit about what I believe about surgery and things that I think are important. One of the most important things is early restoration of continuity. So what does that mean? Fancy words, it says put everything back together again as soon as you can. Whatever you have on the inside, to the extent that it's possible, we should try to use that. We should try to use that to help you absorb calories, help you absorb fluid and electrolytes. So we're big believers in really aggressively trying to get back to the operating theater as quickly as we can and get on with things. Generally, I want to do that as soon as I think it's safe to do. So when patients are sent to us from other institutions, which is fairly common, I usually want to be around 2 to 3 months after the last time someone was in their belly. That lets the dust settle for us surgically, the adhesions settle down, the inflammation isn't so bad, and we can usually do things. There are occasions when I'll push that back a little bit, but generally that 2 to 3 month range is about where I am with most of my patients. I can tell you guys, when I first started doing this, 15 or 16 years ago, we weren't as good at managing. We didn't have the same technology we have to manage TPN. We didn't have some of the surgical tools that we have, and we didn't have growth factors. We didn't have a whole bunch of different things. And so we really had to get every bit of intestine. It was important to try to get, as much as we could. And while that is still important, I must say our ability to get patients off of TPN with shorter and shorter lengths of intestine has allowed us to have a little more freedom to say, gee, that piece of bowel isn't that good, and we're not going to use that. And instead, we're going to focus on this 60 centimeters of really good intestine. Because, almost every patient we've got who's got, 40, 50, 60 centimeters of small intestine is going to ultimately come off of TPN. Depends a little bit on how much colon you have. But so it's just, as the field has evolved, our decision making has evolved. My final point here is I believe in restoration of continuity. I believe in getting everything hooked up, but there are times when having an ostomy is your best option. And what this tends to be is, if you're the circumstance of you're the patient who has fairly short bowel, and your bowel movements are so intrusive into your day that you just can't get out of the house, you can't get out of the bathroom. Sometimes you're better off having an ostomy as far along in the bowel as you can, so that you can have the freedom to not be in the bathroom all the time, to not be having accidents, to be able to go and shop, go to a movie, go out for dinner. And so I think that's something that, again, you build up a relationship between a patient and a surgeon and a team, and you talk about that for the individual. Now, here I've been talking to you about surgery, but this is probably the most important point as a surgeon, which is avoid surgery whenever you can. I always tell our patients the best surgery is no surgery. That's what you want if you can avoid it. So we try to do everything we can to not operate. And what does that mean? Well, we may want to change diet. If you're an adult, a lot of times people come to us and they're eating the wrong things. And we say, here's the things that would be better for you to eat. We change your eating pattern. We're all used to eating 3 square meals a day, but if you have short bowel syndrome, 3 square meals a day isn't the best pattern for you. You should probably be grazing all day, eating 6 meals or 7 meals, each one just a small little nibble. Nobody wants to spend 10 hours a day sitting at a table eating food. but you can have little snacks all over the place and just grab them here and there as you go. We may need, in some cases, things to make your intestines work better. Some cases, things to slow them down, so anti-motility agents. We may need antibiotics at times, although I would argue to most patients, if you're needing antibiotics to improve your function on the inside, there's often something that needs to be fixed. Because if our intestines are working forward and flushing forward the way they should naturally, generally, you're going to be able to function without antibiotics. If you've been on antibiotics chronically and you stop them, you'll feel turbulent because all of your flora are jumping all over the place because you just removed the antibiotics, and people go, oh my gosh, I need them. I have to be back on them. And they become a little bit like a narcotic. You know, you have this antibiotic withdrawal. If you can just ride that out and get through a few weeks, it settles down and you can come off the antibiotics. And occasionally we need probiotics. But the point of this is there are occasions when I see someone with a fistula where I know surgery has to be done right away. But where it's not so straightforward, I'll try to do everything else possible before we go to surgery. But sometimes you get stuck. Even the best of teams just get jammed up. So that's where you come in as a surgeon. So let's talk about some of the common, just again, large areas of things that might come up. The first picture represents obstructions, and the second picture represents dilations. So obstructions. Well, obstructions can be a little more common in the course of your short bowel syndrome, but they, believe it or not, bad obstructions that don't relieve tend to be more rare over time. Why is that? Well, the big obstructions where you have to go emergently to the operating room because something really bad has happened require usually the ability of things to twist or turn on the inside where they can get kinked and blocked completely. But as your bowel gets a little more adhesed on the inside, that freedom of movement is limited. So you might get obstructive symptoms. And these are the kinds of obstructions where you get the crampy abdominal pain, stuff's not going through very well, you need a nasogastric tube, but it does tend to settle down. And 90% of the time, that's going to get better over time. And you want to avoid surgery because if you're going in to treat adhesions, we know those adhesions are going to come back. And so while sometimes you have to do that, and I've done that on many occasions, if you can avoid it, you want to avoid it. Now, dilation. Dilation is a phenomenon that occurs in short bowel patients where the bowel gets stretched up and it gets bigger. And we're not always sure why it occurs. It can occur because the bowel is blocked. But really what we're talking about here is dilation that occurs where there's not an obvious blockage. So when the bowel gets dilated, imagine a thin tube that gets really, really stretched up. Well, that tube wants to squeeze forward and push food out, but it can't. It squeezes, but the contractions don't allow for a propulsive motion. And so then there's a series of operations that we can do called enteroplasties that take advantage of the dilation to try to correct it and improve the way things work. This next image kind of shows you demonstrably what's the difference between if your bowel is dilated or not dilated. If you think about a big pipe and water is flowing through the big pipe, well, for all of the volume of water coming out of that pipe, a relatively small percentage of the water is touching the sides of the pipe. And touching the sides of the pipe is absorbing. So if it doesn't touch the sides, you can't absorb it. Most of it shoots through the middle and you have this big forceful outflow of fluid. That's diarrhea. So that's your bowel movements, and that's losing the calories that you need to grow and develop or to stay healthy and come off TPN. If we can take that big tube and turn it into a smaller pipe, a much higher percentage of the fluid on the inside is touching the sides that you can absorb. And so your output goes down. And so a lot of the times that's our goal, is to reduce the size down and restore that volume to surface area ratio. One of the common ways we do this is an operation called a step procedure. So if you're dilated and you have this big dilated tube, we can use a stapling device that seals the bowel and splits it into a V, as you can see in the sort of the center image and then in the rightmost image. And what that does is it takes this big dilated tube and it turns it into a much more narrow zigzag tube. And that restores the function beautifully. It actually alleviates most of the dilation symptoms. This can be done fairly simply. It's a fairly straightforward operation to do, but there's a lot of detail. And so to do it properly, you really need someone who's doing a lot of these. And I will tell you, it's a fair question to ask that surgeon if someone's telling you about this. Well, how many have you done? Because if they're telling you the truth, most of them have probably only done it once or twice. Whereas if you're in a big center, you're in a place like ours, we've done it 150 times. And so you want to try to get to the centers where people have got more expertise in these things, because the devil is in the details. this is an alternate way of approaching dilation. It tends to be used maybe sometimes more in adults or when patients have a longer length of intestine. It's called a longitudinal excisional tapering. So the idea here is if you have a great big tube of intestine, we can align those staples in a different direction, sort of parallel to the length of the bowel. And we can work along trimming the excess off, and in fact, getting rid of the outside of the bowel and leaving us, like in this picture here, with a much more narrow tube of bowel that's restored down to its normal size. So now suddenly you go from big dilated intestine that isn't squeezing, gassy, miserable, bacterial overgrowth, all that kind of stuff, to nice, small, narrow bowel that can squeeze beautifully. Now, when you do a tapering enteroplasty like this, you can see that curtain of intestine on the outside that's all removed, and that's just going to be discarded. So you have lost absorptive surface by doing this. But the reality is, if that surface wasn't really working for you in the first place, losing it doesn't really change very much for you. And in fact, when you do an operation like in the picture that you can see here, the fourth image, you end up with much better absorptive function even though you have less intestine. So coming towards the end of just this very brief introduction to the role of surgery, and I'll tell you, we'll have the question and answer session coming up, and that'll give us a really good chance to go into specific issues with people. But I would say from a patient perspective or the perspective of a team, when you're considering a short bowel patient, simplistically, I would say if you're not moving forwards, then you're going backwards. What do I mean? Well, I mean that every time you, every week really, but every time you meet with your providers, and ideally much more frequently, you should be saying, what can I do to make my life just a little bit better? That could be a little less TPN volume, so I don't have to pee so much at night, or less frequent lab draws, maybe changing my hours because 14 hours intrudes on my day, but if I could get to 10 hours, I could do it while I'm sleeping and it would just be simpler. So, and then of course, trying to come down off of TPN. So trying to cut my calories, cut my volume, become more enterally independent. I would say from a patient perspective, if you're not making progress, if your needs aren't being addressed, if you're not doing something to make your life better each time, you're probably going backwards. And you need to sit down with your team and you need to say, hey, yeah, what's going on? What's our goal? What are we trying to do here? Sometimes people can almost get forgotten about, and you're just on TPN and you're used to it, the team's used to it, and suddenly 3 years has passed. And in some circumstances, that's not the end of the world. Maybe you just want a break. You don't want to be working with stuff all the time. But I think in the grand scheme of things, we really want to be looking at what can we do to make life better all the time. So I guess I like to think, and I share with our team all the time, guys, if we're not moving forwards, we're going backwards. So what are we going to do better? I believe in transferring early to specialized centers. I think you should. It's never going to hurt you to get more information. Anybody who doesn't want you to get another opinion, you have to really wonder about that person in the first place. Because I'm as specialized at this as anybody in the country. And if somebody said, look, I feel like we're struggling and I want to go see somebody else, I would immediately give them a list of 10 people who I trust, who I value their opinion. I'd say, look, let's go see what they got. Maybe they're thinking of something I'm not thinking of. But I think getting people involved in helping you is a really important part to your care. I believe in restoring continuity early, and we talked about that. I think you should avoid surgery whenever it's possible, but you should not hesitate when it's needed. And I do think sometimes surgeons who are frightened of the inside of an abdomen because it's hostile will sometimes delay surgery. And I often get poor patients coming here with fistulas, for example, who've been, with this fistula for 2 or 3 years, sometimes in the hospital, in long-term care because they can't get out, can't manage. And all they really needed was, sort of tightening up your belt, getting a little brave and fixing it. And so I think you can't hesitate when it's time to do something. And maybe experience in doing a lot of these cases helps you to not be hesitant. Knowing when or when not to operate is really the most important job of a surgeon. It's the technical elements are important, but it's the deciding up to when is the right time to do it. It's really the most important thing for the surgeon, for the patient, and for the ultimate success of that relationship. So everyone, that's the end of my introduction to the role of surgery in short bowel syndrome. Thanks very much for your attention.
Hi, my name is Swapna Kakani. Thank you, IFFGD, for inviting me and having me speak. I will be sharing a glimpse of my 30+ year journey with short bowel syndrome. I was born with a congenital defect of the small intestine called multiple intestinal atresia in 1989, 31 years ago. In 1989, the prognosis to live long with short bowel syndrome and on IV nutrition was unknown. It was actually the surgeon who told us, take one day at a time. But more importantly, my parents were the ones who said, we are going to appreciate each day alive and healthy with this new baby girl. And together as a family, we are going to fight for every milestone, regardless if it comes or not. This is going to be our new normal. I want to say now a kind of a disclaimer that because I was born in 1989, it is important to know that this is just one example or one journey of living with short bowel syndrome long term. And the field, the treatments, the advancements in IV nutrition and medical care for short bowel syndrome has changed drastically in the last 3 decades. The decisions that we have made as a family may be different than the decisions other families may make or even have the options to make today. From day 2 of life, I became dependent on nutrition from an IV, TPN, total parenteral nutrition. I received TPN anywhere from as little as 3 nights a week to 7 nights a week. The infusions could last as little as 8 hours to as long as 16 hours. I would get most, if not all, my calories from TPN, as well as my feeding tube, my stomach. I received nutrition from a gastrostomy tube called enteral nutrition. I have received enteral nutrition 16 hours a day, every day for my first 20 years of life. And TPN, I have received for the last 28 years and counting. There have been only 3 years as a child that I did not receive TPN, but I did not grow or gain weight. I was told, go eat. Please eat anything, whatever you would like. And in the 1990s, we did not know the diets we now recommend for short bowel syndrome and intestinal failure. It was really for the purpose of getting familiar with food. But although I could eat, I was not very interested in eating. And I ate like a bird. I would eat the same meal, drink the same drink for hours at a time. My favorite food, potato chips. The salt I would crave because of the amount of output I was losing. So this is a perfect example of who I was as a child, headbands and all. It's a glimpse of me in the wild, eating potato chips and getting fed with my hot pink nutritional backpack. As a family, we were going to redefine what normal meant for living with a chronic disease, living with short bowel syndrome. No one had defined that, and we were going to beat expectations. I went to eat my feeding tube out, regardless if I was eating or not, to enjoy the party first and foremost. Participate in cultural activities, having to hide the feeding tube underneath my dresses. But I participated and danced just like my peers. And then as a high schooler, did a lot of civic service activities. One example was Habitat for Humanity, of course, the one activity that is in the heat and requires physical stamina, but I love doing it with my backpack on. In my 31 years, I've had 31 central lines. Of those 31 central lines, 25 have been infected by bacterial or fungal infections. But one of my most favorite numbers is that I've had the current central line I have now for the last 5 years and counting. We unfortunately had to repair it a couple months ago, but thankfully we were able to repair it and not replace it. So 5 years and counting. And my most favorite number is that it's been 14 years and counting since my last central line infection. going to school, I went to school just like my peers, but I went with two backpacks. One was my nutritional backpack and two was my academic backpack. I went to school like the true turtle, and I was pertinent to not use my backpack as a weight, as a burden, but rather as a driving force to move forward, to educate my peers, and to understand what it is to live life with IVs and tubes. It was my normal to go to school with IVs and tubes. In the middle of college, I had one more abdominal surgery with the hopes of this one hopefully being the last, but this one being the one that lets me be free of IV and tubes, or at minimum be free of TPN. Unfortunately, it resulted in complications that then resulted in more surgery, more complications at centers all across the United States. For the first time, I was getting adult care. I had no transition of care. Instead, I was referred from a pediatric center to an adult center, and that was it. My parents and I put my care in our own hands. The complications I developed were called fistulas. I had fistulas between my skin, my small intestine, my large intestine, and also my bladder. I was urinating food and bile, and the same food and bile would drain spontaneously on my skin. I was raw both inside and outside. I was struggling to find motivation to move forward. I had to stop college and move back home. It was at this time that our family learned the hard way, the importance of right care at the right place at the right time. We traveled to subspecialty centers across the country discussing my next option. I made the difficult decision to remove my small intestine and large intestine, which I fought for my first 24 years of life, to then only be dependent even more on TPN and IV fluids 24/7, no food by mouth, and all my GI contents drained into a drainage bag that I held on my leg. But this didn't stop us. I was going to continue to defy the meaning of disease. The picture on the left, we went to Big Sur in California, rode the Pacific Coast Highway with my backpack on. You would never know in the picture on the left that I was receiving TPN or IV fluids 24/7, and I had a drainage bag on my leg and I could not eat solid food. We ended that trip at a family wedding on the right. And in this period of time, I graduated from college. But the next step was soon, and that was transplant. I made the difficult decision to have a small intestine organ transplant. In June of 2014, I was on the waiting list only for 15 days. Since the transplant, I've had highs I've only dreamed of since I was a child. I no longer have a feeding tube. I can eat to my heart's desire with some limitations. And the best part is I don't have pain before, during, or after eating the meal, something I was very accustomed to growing up. But with the highs comes lows. Transplant is not a cure. It can be an exchange of hardships. I've had bacterial and fungal infections requiring more surgery. I've had hip replacements due to a bone disease. I now have a permanent stent in my right ureter, and I have had to get back on TPN to maintain weight and hydration. This is what today looks like. A lot of times chronic disease can be overwhelming. But what my dad always says is, Swapna, you cannot live just for today, because he knows, a lot of people in my family know that I run 100 miles per minute, but rather you have to live for tomorrow. So with chronic disease, a lot of what we do is continuing to show up at doctor's appointments, show up and having to make hard decisions, coordinating care, managing our symptoms daily, weekly, monthly. It has, because of the 30 years of doing this, I've learned that this part of our lives cannot be sacrificed, and respecting the process and the journey allows us to thrive not only for today, but really more so for tomorrow. 65 surgeries in 31 years has taught me that, one, we have to speak up as individuals with chronic diseases, with chronic rare diseases. Your view is important. It is unique. It is okay to be the educator, the trainer, to teach others what it is like to live with the disease, teach decision makers, doctors, and more. We are our best advocates. I wish I was told that when I was younger. Next is knowing that you are not alone. Find others. My life has been changed drastically by finding fellow gutsy gals. We have met each other through Facebook, Instagram, social media, as well as conferences. We now call ourselves gutsy gals with good for nothing guts. It is the text between these women and more, and phone calls, that drive me to continue fighting every day, because I know that someone else gets it. And finally, respecting the big picture. This is what drives me to continue to fight and be an advocate and fight for the milestones we dream of, regardless if they come. Because it is understanding how far we have come to then appreciate how far we will go. Thank you.
Hi, everyone. My name is John Mahalchak, and I'm here to share my perspective on living with chronic disease and intestinal failure. Just before I start, I wanted to say a big thank you to IFFGD for this invitation, not only to share my story with you guys here today, but also for many other opportunities they've given me over the past year or so. So today I'm going to kind of briefly just in one slide here, just discuss intestinal failure. And then the bulk of the time, I'm going to share with you my journey, some tips and tricks I've learned along the way. And then at the very end, I just have a challenge I'd like to pose for everybody. So intestinal failure occurs when your body is not able to properly absorb nutrition and fluids when you take them in orally. And because of that, patients then have to rely on intravenous nutrition, which is called TPN, or tube feeds, which is called enteral nutrition. That, along with the TPN, sometimes you also require additional IV fluids as well. This can happen for many different reasons. Common ones, short bowel syndrome, inflammatory bowel disease, among others. And this is kind of where my story becomes a little bit different. A lot of these disorders are things you're born with, but for me, as you'll see in a second, that wasn't the case. So as I would say, most GI stories are complex, and mine is no different. It seems to me, talking with other folks in the community, that these very rarely come in singles. Once you get one GI disorder, it's not uncommon to end up with multiple. So my story starts in the freshman year of college. I was getting ready for finals, and I had an episode of severe abdominal pain with some nausea and vomiting. Not quite sure what was going on, went to get checked out, and it turned out that my gallbladder had to be removed. After that, I ended up getting recurrent episodes of acute pancreatitis So my pancreas enzymes would go very high. I'd end up in the hospital without withholding food to make the pancreatitis go away, and then getting treated with medications and fluids. This was happening for a while, and as I said, when I would be in the hospital, I would end up on enteral nutrition or tube feeds to kind of give my pancreas a bit of a rest. This progressed, and I ended up having a total pancreatectomy with auto islet transplant. So with this surgery, what they do is they go in, they take out your pancreas, they take the islet cells from your pancreas and they put them into your liver. So your liver then does double duty. It works as a liver, but it also has those islet cells in it to prevent you from becoming a brittle diabetic. When they do this, they also do a Roux-en-Y gastric bypass procedure where they adjust the exiting of your stomach, and then they take out portions of your small bowel as well. When that happened is when I was first really diagnosed with malnutrition. And as a result of the surgical anatomy changes and some other things going on at the time, I wasn't absorbing anything. So I ended up being placed on total parenteral nutrition, or TPN. So I have a port that's in my chest, and I was getting all of my nutrition as well as IV fluids via that port. I also, as a result of the surgery, ended up with gastroparesis. So my stomach wasn't emptying properly. And even when it did empty, things were not moving through sometimes at all, but definitely not at a normal rate. Because of that, I had a feeding tube placed as well that would allow me to empty my stomach so that I wouldn't vomit, and then to eventually try to switch over to enteral nutrition so that I could get off some of the TPN. So as I mentioned, that's what happened right after the gastroparesis. And then this led kind of to multiple gastric revision surgeries, my most recent just being back in March. So now I have, they've taken out like the bottom third of my stomach, as well as a good portion of my small intestine. And I have, aside from the port that I mentioned earlier that I use for fluid and medication, I also have two feeding tubes now. So I have one that's just in my stomach, and that helps keep my stomach empty due to some of those gastroparesis syndrome symptoms. And then I have the J tube, which goes into my intestine, which, due to the malnutrition and the issues with my the intestinal failure, I can get enteral nutrition when I'm able to absorb. And thankfully, for the past few years, I've been able to stay off of the TPN, the IV nutrition, to keep my gut working. But it's always a possibility that we may have to go back or forth. My nutrition markers are monitored very closely so that we can make sure I'm getting the adequate nutrition that I need. So with that, so the IV fluids run all night, and then the tube feeds run all day. So I'm always hooked up to my backpack, just making sure that I'm getting all the nutrition and everything I need. So that's kind of my journey. So through this journey, I have learned quite a bit. And those are some things I'd like to share with you now. And probably the biggest thing I've picked up on is that treating chronic illnesses requires a team approach. It's not something you can do by yourself. And every team requires a leader. So after establishing my team and switching to something at my hospital called the Enhanced Care Program, my hospitalizations dropped to less than 2 per year. This is something that happened recently. I've only been in this program for about 2 years, but it's been absolutely remarkable. As you'll see in a second here when I show you who's all on my team, it's a multidisciplinary care setup, which means I have different healthcare providers from across the spectrum who are all working together to help keep me healthy. And I was lucky enough to live in a city here in Pittsburgh that has a large academic center. So thankfully, I did not have to travel across the country to put my team together, which I understand is something that happens quite a bit in this area. Having said that, I did make one trip to get a second opinion from a physician in Nebraska who I met at a conference. But I do have to say I've been very lucky that I've been able to stay at home during all of the care that I've needed. So, like I said, my team's multidisciplinary. It has a lot of people on it. So I have a primary care physician, as I mentioned earlier, that we call that the enhanced care physician. And she's my leader. She's responsible for my day-to-day care and kind of keeping everybody else on the same page. I also have a GI nutritionist who makes sure my nutrition markers are okay, handles any problems that would occur with my central line or my feeding tubes. I have a dietitian, again, who helps me with the tube feeds and different additives and things that I would need for my nutrition. A pharmacist to keep all my medications straight, a home infusion company to help make sure I have all the supplies I need at home to keep me out of the hospital. I also have a mental health therapist, and I think this is understated. And I just want to spend a second on this. I have become a firm believer throughout my experience here that you cannot have good physical health without good mental health. Did not realize this at the time, but looking back, as I was getting sick, I also was experiencing some severe cases of depression. So working with a mental health therapist has really made a huge difference in my care. And I like to share this with everybody because I do know that there is stigmas attached to mental health. And as my therapist tells me all the time, you know, if you're somebody who's going through a severe chronic illness and you're not a little bit depressed, she would be a little bit more worried about you. So I do just like to share that with everybody as well. I also have a surgeon on my team. As I said, I've had multiple gastric revision surgeries. So he's able to help with that, and he's able to help with my feeding tubes as needed. I have an endocrinologist. This is due to that total pancreatectomy I had. So they help keep my sugars in balance for me. I also have a pain management physician on board and then a physical therapist. So there is one person I left off of my team, and I did that on purpose, and it's me. So I am also a critical member of my team, and you are a critical member of your team as well. As patients, we have a lived experience that cannot be taught in textbooks. However, to be an effective team member, being prepared for your appointment is very important. So I'll show you here in a second, but I use a worksheet to document all my visits, and then I keep all these pertinent records in a binder. Here is the worksheet. It didn't copy over to the screen real well, so I'll kind of glance over it, but I will make this available through IFFGD or through a link at the end, however we decide to go down that route. But it basically just lets me document everything that happened at the visit, so any issues that were addressed, changes in plans of care, new medications, and then anything I need to complete follow-up. So going over kind of my story now, I do want to just end, I have a couple seconds left here with just a challenge for everybody. So I hope that today I've been able to show you that there's power to share in sharing your story. And with that, I would challenge everyone here listening today to share your story with one other patient or a healthcare provider. It doesn't have to be somebody you go to see that you have a physician relationship with. And then as a follow-up to that, at your next GI visit, just tell your GI provider why you love IFFGD and the resources they make available. So thank you so much for allowing me to share my story with you. If you have any questions, please feel free to reach out via email. And I look forward to chatting with everybody during the Q&A. Thank you.
Hello and welcome back. We hope you enjoyed that very informative session about short bowel syndrome and intestinal failure. I know you heard from a physician, a surgeon, and then two patients living with short bowel syndrome and intestinal failure, which was a lot of information to take in. Before we move to some questions that we have, I do want to welcome you back to the Norton Educational Series 30th Anniversary Edition. For those of you who are just joining us midday on Saturday, welcome and thank you for participating in this virtual event. This event is in honor of Nancy and Bill Norton, the founders of IFFGD, who started this organization 30 years ago from their kitchen table as a way to help other people understand better living with GI illness. The IFFGD organization was founded on a desire to educate, and we try to continue that tradition today through this Norton Educational Series. With me for this hosting session is John Pandelfino. Those of you who missed his introduction earlier, he is one of the world experts in GI illness. He practices at Northwestern University, where he is the chief of the GI division, and he is absolutely one of the top experts in the esophageal area, which is upper GI, and gave a wonderful talk this morning about esophageal disorders. If you missed that, please remember that both days of programming will be available on our YouTube channel and on our website starting on Monday. And so you can always watch, rewatch, share with your friends who may have missed the program, and be able to refer back to that. So going on to this session, which is about short bowel syndrome and intestinal failure, Dr. Mercer talks about an ostomy for people with short bowel syndrome. And he actually says that sometimes that can be very beneficial if there's a lot of output. How often do you see this happening in your practice?
Well, I mean, it's certainly something that does happen. It doesn't happen for everybody, but certainly it can be something that helps people's quality of life. You know, it's pretty amazing what has to happen with the GI tract. When you think about, you know, we drink about 2 liters of fluid a day. We make a lot of saliva that we swallow. And then there's a ton of secretion of fluids into the small intestine. And in the end, if you think about it, just kind of roughly, we take in about 10 liters, or there's 10 liters delivered to the small intestine, and it has to absorb about 9 liters, so 90% of that. And then it delivers another liter to the colon, and the colon has to really take out about 90% of that, so that we were left with, when all is said and done, about 100 cc's or 100 milliliters of fluid or material at that point. So it's no big surprise that there are a lot of fluid shifts that occur. And depending on where the dysfunction is in the small intestine and which part of the small intestine is not working very well, you know, it can affect different things. And sometimes it's easier for people when they're delivering these huge amounts of volume to control that with an ostomy, as opposed to actually having it be dumped into the colon, overwhelming the colon, and then having diarrhea. So there are definitely some opportunities to improve people's quality of life with ostomies. We see that often too with people with chronic constipation. You know, when delivery to the colon is going to be an issue and there's a backup, it helps decompress that obstruction. So definitely different options. And I think these are things that require a really good communication between your gastroenterologist, your surgeon, you know, your pharmacist, your dietitian, everybody, and most importantly, the patient, because I think in the end, the patient's preference is really the thing that's driving. We know that you're going to tell us how to improve your quality of life the best way.
So just leading from that, you know, we had a great question from the audience during this session, and that was about building sort of a healthcare team. So John Mahalchak mentioned his team, and I think that, you know, that is something that sounds great. But how could somebody how do they do that? How do you figure out who your team members should be? And
yeah, so if you think about it, when you think about a team, a multidisciplinary team, especially in GI and these kind of problems, you know, you typically have a gastroenterologist, then you'll have probably a surgeon, you'll have a pharmacist, a dietitian, potentially behavioral health to help. And then even on top of that, you know, the primary care physician to help with a lot of other problems that may be affected by the fact that your nutrition is affected. So if you think about all of those particular people on your team, it can be pretty daunting. You know, are you going to be able to come to clinic on one specific day where all of those people are available? Well, no. What you need to have is great communication. And I think now one of the benefits of Zoom and these telemedicine visits is now that you don't have to coordinate everything into one clinic where you come in and you have 5 different providers who are there to see you. Now you can interact with them separately, and then they can communicate between electronic medical records and amongst themselves. And now it's a little bit easier to do that. But as you said, probably the most important thing is picking the right people, right? So I think, you know, one of the things is that you have resources like IFFGD that can direct you to the physicians that actually do feel comfortable taking care of these particular problems. And I think that's the most important thing is, do they have experience? Do they work with other people? So always look for people who already have relationships with surgeons. For instance, at Northwestern, we tend to pair each other up with other providers. So for me, I know that my surgeon is Eric Hungnes. We work together. I have a behavioral therapist that I work with and a dietitian that I work with right off the bat. So we have that team established. So when you come to see us, it's already there. Now, sometimes you may want to pick the right people. And what we're seeing now with telemedicine is that you can actually have team members that are not in the same institution. So there's not that restriction, you know, and I collaborate with people on the West Coast, on the East Coast, on patients, and we work together. So there's a lot more flexibility now with developing a multidisciplinary team.
Fantastic. And I guess the key is really communicating with your gastroenterologist or whoever your primary physician is that this is what you want to build. And would you consider the quarterback of the team to be the gastroenterologist?
Yeah, most of the time I would say probably is the gastroenterologist. I think in some instances when you see someone like Dr. Mercer, I think when they have such a specialized clinic, you know, Dr. Mercer could certainly be the quarterback in that situation. But for the most part, I think it winds up being the gastroenterologist. Remembering though that they have to work in collaboration with their primary care doctors, their behavioral medicine providers, dietitians, and of course the surgeons when needed.
Fantastic. So another thing that has come up during this session that I wanted to just touch on briefly for the audience is the use of tube feeding. And so I know there are different types, there are different options, and they're not one size fits all. And how do you as a gastroenterologist or physician sort of make that distinction for different patients?
That's a great question. In fact, Dr. Stein, who provided one of the lectures, really taught me a lot about tube feeds, because one of the things that happens is that when people get placed on tube feeds initially, it's typically in the hospital. And one of the things I didn't realize is that there is a disconnect between what happens in the hospital and what people need when they become outpatients. So what might be good for someone when they're hospitalized and acutely ill may not be the right tube feed when they go home. And what we find out is that patients come in and they've been on the same tube feed for a year, 2 years, 3 years, and no one has really done an effective job looking to see whether or not that is a carefully curated recipe for that particular patient and the disease that they're dealing with. And this is really where I think working with someone who's a specialist in small bowel diseases and nutrition is really important, because these tube feeds can be tailored for specific diseases. In fact, they can also be tailored to accommodate other problems that that patient may have, whether it's kidney disease, diabetes. So it's extremely important to think about all of those things. So for instance, one of the biggest mistakes I made early on is that when I had people on products that had a ton of lactose in them, and patients would be having bloating and diarrhea, and they learned to live with it. And if they would have come to me, or if I would have been more well-versed in tube feeds at that point in my career, I would have known that I can find products that have less lactose for those particular patients. And of course, as I've learned throughout my career, now we can actually tailor this. So we can look at caloric content. If we need to deliver more calories with less volume, say for instance, someone's got overflow in their ostomy, we can reduce that actual volume by increasing the calorie counts. So there's a lot we can do to tailor your nutrition therapy by using different types of tube feeds.
Fantastic. Again, the underlying message here is to talk to your doctor and make sure that if something is bothering or you're having symptoms, like Lynn Chang said earlier, that you mention that to your physician. I think so often as patients, and I know that I'm guilty of this personally, is that I will have something that I deal with, and then I get with my doctor and I think, well, that's not really that big of a concern, and I don't think to mention it, when actually it might be something that you can help me with. So that's fantastic. Thank you so much for those two things.